Right. Good afternoon, everyone. Thank you, Sandipana, for your kind words of introduction and your mentioning about this dialysis unit. And to be honest, it's not one person's effort, and I should mention my colleagues that time, Dr. Lalindra Dias, and then Dr. Hasheni, and that time director, Dr. Aruna Jayasekar, who helped me a lot. And then we were able to just start that. Before going into this, I should mention just we have just very primitive dialysis, but we don't have the ideal setup to manage acute kidney injury, to be honest. You will realize it as the presentation goes on. I will tell you why. So I thought of talking a little bit about acute kidney injury, mainly because this is something which is applicable to basically almost all the departments in this hospital, irrespective of what the organ or the system they are using or they are treating, including the forensic pathology. Right. Before going to the presentation or the stuff, I would like to mention two cases. These two patients are real patients whom I came across within the last 14 days in this hospital. This is the first patient I would like to mention. As I go on the presentation, I would be discussing the whole case. A 70-year-old female or lady presented to the surgical unit. She had a cellulitis with a wound in her left foot. And on presentation, she was found to be having sepsis with the infection of her wound. And she underwent wound debridement, and I'll leave it there and I'll let you know what the other findings as we go on. The second patient, this patient came to the medical ward, again a 71-year-old male. He came with fever, chills, and feeling very unwell. On presentation, he was hypotensive and he was basically delirious on admission. Little bit on the background, this patient of course a known diagnosed patient with chronic kidney disease and was very recently discharged from our hospital after dialysis for an acute kidney injury on top of his chronic kidney disease. So my presentation I would be trying to touch upon following things, just a little bit of structure and function of the kidney and the definition of acute kidney injury. Etiology and how you diagnose, and basic investigations what we should do or think of doing when you come across or when you suspect AKI, and the principles of management and bit about complication, not much. Right. This is just to, for the completeness I have put this slide, everybody knows we have two kidneys, and when you take the cut structure, you can see on your left the external appearance of kidney, and then when you go for a longitudinal section, you can see the mainly two areas, cortex and medulla, and this is consists of what we call the nephrons or the functional units, and there is about million nephrons in one kidney. So the kidney is a well-perfused organ. As you know, about 25% of your cardiac output goes through the kidney in 1 minute. This is the nephron or the functional part of our urine producing part of the kidney. I'm not going to go in details because everybody has gone through this during their medical school days and even after. So it is basically consists of this tubule and the Bowman capsule and also the capillary network. So what are the main functions of kidney? You can see two main functions basically. I'm touching on the excretory function and the secretory functions of the kidney. So what are the excretion functions of the kidney? Kidney is involved in removing of excess fluid from the body and also removal of the waste products. Basically we know the ureas and creatinine and nitrogenous waste products. And the other excretory function is to maintain the acid-base balance by changing the, or by the way of doing balancing the acid and bicarbonates. Then the management of regulation of the electrolytes in the body. So what are the secretory functions? Those are the mainly three different hormones involved. The first one is the renin, which involves in the regulation of blood pressure. As you know, this renin angiotensin aldosterone pathway. I'm not going to detail of that. And the second one is the production of erythropoietin, which regulates the production of red cells in the body. Third one, the metabolism of vitamin D. Kidney plays a major part in regulation of vitamin D synthesis. So, therefore, it is involved in the regulation of calcium uptake. So, what is the definition of acute kidney injury? This is, of course, from the kidney disease improving global outcome definition. There are three major criteria which we can use according to the KDIGO guidelines. This is first thing is you go by the serum creatinine. If someone's creatinine rises by more than 0.3 milligrams per deciliter, or in micromoles 26 micromoles within 48 hours, or within 2 days period, we consider it as acute kidney injury. Also, if you don't have two readings, but if you think that like the person's creatinine has risen more than 50%, that is more than 1.5 times the baseline, which is known or presumed to have occurred within the previous 7 days. So you can take either if you know that it is, or if you presume that it has occurred within the 7 days, still you can diagnose AKI. And based on the urine volume, you can even diagnose AKI by measuring the volume. If the urine volume for 6 hours is less than 0.5 mils per kilogram per hour, then you can diagnose AKI. This is a diagram to show the conceptual model for AKI. So you can see this multicolored row of circles from normal to the extreme of death. So the normal kidney, and then the kidney in yellow but not normal, that is increased risk on your, and then going into the purple, damage to the kidney, and then reduction in GFR, and then it will lead to kidney failure and ultimately death. So this shows how the GFR and the damage relates to the AKI and how the complications are. Let me just get this. I don't know how to use this. Right. Can you see the normal stage? And then this is the death. So all these stages are the stages of kidney damage and kidney failure. So normal kidney still can get complications, but if there is increased risk, I will come to what increased risk is. If there's increased risk, then of course the complications go up. But still you can see the GFR, this blue graph, GFR is normal, even though there's increased risk. When it comes to the damage stage, only you see the GFR comes down, and the damage, depending on the degree of damage, you can see from down this lower triangle, as the damage goes up, the GFR goes down, and that leads to the kidney failure. So from this stage, you can get the reversal, or the GFR can get improved, and then the damage get reversed, and then you can even go to the level of normal kidney or increased risk kidney. So this is the normal conceptual model for AKI. Just to tell you what happens, schematic representation of renal failure. And when you get the damage, you can get this tumor or the markers, biomarkers, which are indicative of the damage of the kidney. But unfortunately, we don't have much of access to for clinical use all these things, even though they are like being described. Good. Right. So how do you grade or classify acute kidney injury? There are mainly 3 stages of acute kidney injury. I just want to mention to the juniors here, this is not CKD stages, this is acute kidney injury stages. So we have three main categories or stages of acute kidney injury. The stage 1 is defined there are two criteria to go by classification. One is based on creatinine or based on urine output. So the stage 1 is where I mentioned as earlier, your creatinine levels going more than 1.5 times the baseline is considered AKI. So from 1.5 to 2, up to 1.9 times the baseline is considered a stage 1 kidney disease or acute kidney injury. When it comes to urine output, it is the same 0.5 mils per kilogram per hour. For up to 12 hours, you take it as stage 1. But if it goes beyond, you consider it as stage 2. But based on creatinine, that is 2 times the baseline or up to 3 times, not 3 times, so just less than 3 times, that is 2.9 times the baseline, we consider it as a stage 2 kidney, acute kidney injury. And the stage 3 is where the creatinine is 3 times or more than the baseline. Or sometimes, figure, sometimes you call it as 4 milligrams per deciliter or above. Or if you have started patient on renal replacement therapy, which I will talk to you later, then you consider it as stage 3. Right? And when it comes to urine output, it is less than 0.3 mils per kilogram per hour for more than 24 hours. Or if anybody is anuric for more than 12 hours, you can consider it stage 3. This is important because the management differs from stage to stage. Right. There is another criteria for staging, which is based on the severity as well as outcome, which is called a rifle criteria. A rifle has come from R for risk, I for injury, F for failure, L for loss, and E for end-stage renal disease. We'll come to one by one there. The risk stage is where you get the same stage 1, that is creatinine raised 1.5 times the baseline, or the same 0.5 ml per kilogram per hour urine output for 6 hours, or more than 6 hours, or estimated GFR decrease about 25% or more. So that is the risk stage. When it comes to injury stage, the GFR decreases more than 50%, or the creatinine doubles, or the urine output reduction stays more than 12 hours. So that is the injury stage. And when it comes to failure stage, we define the failure as GFR of more than 75% reduction, or tripling of creatinine, or urine output less than 0.3, that basically is stage 3 in the previous classification. But the rifle criteria considered the outcome as well. So outcome wise, if there's loss, that is the persistent acute kidney injury lasting for more than 4 weeks, is considered a renal loss. And if the patient needs renal replacement therapy going for more than 3 months, then you consider it as end-stage renal disease. So how common is acute kidney injury? Unfortunately, we don't have our own data, and it is common to most of the other parts of the world as well. For some reason, unfortunately, there's lack of evidence compared to other systems, particularly the cardiovascular and stroke and all. The renal data is lacking. This is one of the statistics I got from the publication from International Society of Nephrology about a couple of years ago. They estimate about 13.3 million cases of AKI per year worldwide. And out of that, only 2 million occurs in so-called resource good settings or the developed settings. So 11.3 million occurs in low and middle income countries. And worldwide, about 1.4 million dies every year of acute kidney injury. When it comes to hospital admissions, it is estimated about 3% of hospital admissions are related to acute kidney injury in the low and middle income settings. That is applicable to us. This is another publication. Again, this of course a very old data from 2004-05 time from US data, but their annual incidence of community acquired acute renal failure is approximately 100 per 1 million population. And they say only 1% of hospital admissions, at the time of admission, the patients had AKI. However, there's this hospital-acquired acute renal failure that is 4 times the community-acquired, and it comes to 20% of all critical care admissions. That is 1 in 5 patients getting into the critical care has AKI. So that's a significant number. This is another publication which again talks about the critically ill patients who needs attention for acute kidney injury. This study again from like about 20-year-old data, but again they have concluded the period prevalence of acute renal failure needing renal replacement therapy goes up to like 5 to 6% of all admissions, and then they are leading to high hospital mortality. So how do you classify the causes of renal failure? This is the traditional way of classifying based on the cause of renal failure. So 3 major. First thing is pre-renal acute renal failure, where the cause is before the kidney basically, and the renal or intrinsic renal, and then the post-renal. Post-renal is where the cause is beyond the kidney or after the kidney, basically the urinary tract. So when it comes to pre-renal causes, the main reason for pre-renal renal failure is acute kidney hypoperfusion. That will lead to renal ischemia and leading to low GFR. Out of the all causes of acute kidney injury or acute renal failure, this is amounting to 2/3 of cases, up to 60% of cases are due to pre-renal causes. And this is again common for even the critical care setting or the ICU patients. So the main causes, as I mentioned, this is hypoperfusion. So it could be due to the volume depletion, such as patients coming with dehydration or hemorrhage, or sometimes it could be the low perfusion due to poor cardiac output, such as patients with congestive heart failure. Third thing is systemic vasodilatations, where there is no volume depletion or the cardiac function is okay, but patients have low circulatory or effective perfusion due to shock or anaphylaxis or even other causes of shock like sepsis. What are the intrinsic causes or renal causes? They are again about 1/3 of cases are due to renal, and mainly due to what they call acute tubular necrosis, which can be secondary to toxins or intrinsic renal diseases such as glomerulonephritis, which are counting to up to like 1/3 of cases. Post-renal acute kidney injury is due to basically the obstruction of the flow of urine, which can occur at any point from kidney downwards in the urinary tract, and this of course is amount to about 5% of cases. This is another classification of causes of acute kidney injury. So you can classify it as community acquired and hospital acquired. Why this is important? Again, this is important in the point when it comes to the management of the patient. So the community acquired ones, which you see on your left, are mainly the infections. There are 2 types of infections. They separate because of the tropical infections and the other infections. Tropical infections are common to tropics, and then the other infections can be universal. So common things are leptospirosis, dengue, and malaria. Of course, we don't see much these days in our settings. And the other infections such as pneumonia, skin infections, GI, and all the other infections can cause or can lead to acute kidney injury. Then the acute glomerular diseases, as I mentioned earlier, and then there are obstetric causes and underlying chronic diseases. Herbal remedies and patients having trauma can lead to AKI. And then another significant amount of cases we come across are snake bites, and then the toxins. So major causes of hospital acquired are major surgeries, hemorrhage, infection, septic shock, drug toxicity again, and then underlying chronic illnesses which can lead to acute kidney injury. How do you diagnose acute kidney injury? So the basics still applies. You take the history and you examine or look for symptoms, and then you examine the patient for signs, and then evaluate with the investigation. So what are the things in the history? So you have to look for any predisposing conditions or comorbidities in every patient, whether they are coming for something else. So whether they are at risk of any acute kidney injury. That is important because like if you don't anticipate, you might end up getting a very advanced stage of acute kidney injury, or even patients leading to loss of kidney functions. So what are the symptoms? So symptomatology of course is very non-specific, but they can have all the symptoms such as malaise, anorexia, nausea, vomiting due to raised nitrogenous waste products, and then they can have pruritus. They will have either dehydration or sometimes very rarely fluid retention as well. Confusions, convulsions due to uremia. Right. What are the things in the examination? What are the things in the signs, in the form of signs? So the patient's blood pressure is something very important. You have to look for and record blood pressure. Hypertension is one common presentation, and they will have fluid overload. If they have fluid overload, they will develop edema or even fluid in the lungs, where you get bibasal fractures and raised jugular venous pulse when there is fluid overload. If the patient is dehydrated, then they will have symptoms of postural hypotension. So you need to look for the blood pressure and just check for any postural change, and also poor urine output or reduced urine output. Here I have put palpable bladder. This is important, particularly when if there is like post renal cause or obstructive pathology, because we come across some significant number of cases who are coming with obstructive uropathy leading to acute kidney injury or even chronic kidney disease for that matter. So the examination, of course, input-out measurement would come as a management protocol as well, but then you have to have some idea about what the output is. So what are the investigations? So the basic investigations, you have to look for the urine. So of course we don't do much urine dip, but you have to do urine full report to look for basically hematuria, proteinuria, any other abnormalities. Then ECG to look for changes due to hyperglycemia and arrhythmias. And the biochemistry includes, you need to do the blood gases, full blood count, urea electrolytes, renus and the other liver function tests, CRP and ESR, and the calcium. The blood culture and urine culture is important in case of infections leading to acute kidney injury. Imaging, again you have to do the imaging of renal imaging as well as the imaging including the chest x-ray. CT, of course we might consider doing CT, but it's not a routine test for acute kidney injury, but in special instances we might have to go for CT KUB. What are the other other tests or special tests which we don't routinely do, but then we might have to consider? Those are creatinine kinase and then the blood picture to look for any other like supportive evidence to look for causes such as like hemolytic uremic syndromes. You might look for microangiopathic hemolytic picture, and then the myeloma screen because in certain instances people with myeloma they will be presenting like first presentation with some acute kidney injury or renal failure. Then the vasculitis screening looking for renal causes or intrinsic renal disease, and then urine osmolality and cast again show in the diagnosis of cause of renal failure. Renal biopsy and angiograms or vascular assessments, those are also needed, but not routinely or not acute setting most of the time. Coming back to my patient again, this is the 70-year-old lady who came to surgical wards with the cellulitis of left lower leg, and she was having sepsis with wound infection, underwent the lower limb wound debridement, and on examination the cellulitis with some tissue necrosis, but however she was hemodynamically stable at the presentation. She had reasonably good sugar levels. Investigations revealed hemoglobin of 1 gram and a white count of 19,000 with neutrophil leukocytosis of 91%. Her creatinine 1.95 milligrams per deciliter, but however, unfortunately, we didn't have any baseline value for her because she didn't have any previous history. Her urea was raised to 12.36, sodium was 122, and potassium was 5.65. Blood gas showed a pH of 7.23 and bicarb of 15.9. So, any thoughts about what is going on? Obviously, she had sepsis secondary to infection, but however, she was hemodynamically stable, but there is evidence of acidosis with raised creatinine. So, has she got AKI? Anyone says no? Most likely, okay, right. So, she fits the criteria. What stage is it? We were grading the stages. Well, it could be 1 or could be 2. Definitely it's not 3, right? Okay. So, what are the possible causes now? We talked about could be most likely pre-renal, most likely sepsis causing all this, right? Okay. Going to the second patient. This is the 71-year-old gentleman who came to the male ward, fever, unwell, chills, found to have hypertension on presentation, delirious on admission. Background of chronic kidney disease, was recently dialyzed for AKI on CKD. He was delirious hypotensive. There was purulent discharge from femoral catheter site with the catheter in situ. And there was reduction of urine output reported by the family. Examination of abdomen was fine, but the chest showed coarse crepitations. On investigations, his hemoglobin was 6.2, white count of 9.6 with the neutrophils of 80%, CRP 236, creatinine of 5.44 and urea of 24.3. So what do you think? Has he got AKI or is it just CKD? Right? He fulfills the criteria for diagnosis of AKI. And what stage is it? It's more than 4 milligrams. So it is stage 3. Okay. Right. What are the possible causes now? Again, sepsis. Okay. So going back to my presentation, I'll come back to the cases later. So what are the principles of management? So any patient whom we are suspecting or who established AKI, so we need to assess their fluid status, and depending on the requirements, you need to start on fluid resuscitation. Right? Not everyone needs fluid resuscitation, but case by case. And then you have to avoid any exposure to nephrotoxic agents, and you have to treat the cause. So if it is infection, you have to start antibiotics and get the proper doses, right doses, based on their renal functions. And if it is intrinsic renal disease, you got to review their medications again, whether they are toxins or medications related, or if not, if there is any other indications such as like you might even consider starting them on disease modifying drugs for glomerulonephritis and all that, steroids or immunomodulators. So based on the presentation, you have to review their medications. And if it is obstruction, what do you do? That's where we need to get sometimes the help of our surgical colleagues to relieve their obstruction, whether just simple catheterization or whether they need more than that with maybe a calculus removal or nephrostomies or even surgery. And the last in the form of management is to replace the function, that is to start them on renal replacement therapy and manage the complications of acute kidney injury. So those are basics. I'm not going to go into details of each and every case because it is you have to tailor-made the prescription. This is of course the stage-based management of AKI. Sorry about the quality of the slide. I will read this for you, but if you can see the top, there are the AKI stages are given here. this is high risk, but they don't have any extreme left is high risk, but they don't have any acute kidney injury. But stage 1, stage 2 and stage 3 differently. So what do you do with the high risk patients? So the first thing is discontinue all nephrotoxic agents when possible. So even if the patient is not having AKI, you have to anticipate any high risk, if particularly in the patients in ward patients or patients who are admitted for medical care into the hospital. So discontinue all nephrotoxic agents when possible. So if you can stop, just stop. It doesn't mean that you have to stop everything, but you have to see if you can stop them. And then the second thing is ensure volume status and perfusion pressures. So if the patient is hypotensive or if their perfusion is not good, then the kidney is going to get affected or they will have a high risk of developing AKI. So ensure the patient is well hydrated, particularly patients who are like coming for procedures, surgical procedures, obstetric procedures. They may be kept fasting overnight, maybe even like more than 12 hours, where you need fasting for just 6 hours. Patient must be fasting one day and then maybe casualty list, you can't do it, and then you postpone it to the next day. Patient will be kept fasting again the previous from the same night, right? So you got to be very careful. This is particularly for our juniors. So you have to make sure that their volume status is maintained. Then if you think that they need to be monitored for hemodynamics, particularly when they are like acutely ill patients coming with dengue or leptospirosis, where there is high risk of getting hypertension or low volume status, so you got to monitor their hemodynamics and record them. And then you need to assess the renal functions, that is the renal creatinine and urine output at least. Then the fifth one is avoid any hyperglycemia, because the hyperglycemia is particularly increasing the risk of acute kidney injury and the poor outcomes if you have acute kidney injury. So anybody who is having glycemic problems or control problems, or even somebody who is not having diabetes but having problems with glycemia acutely due to acute illness, you got to be very careful about their glycemic status. The last or the sixth option for anybody who is at high risk is if you are going for the use of radio contrast media, radio contrast procedures. So if there is high risk of radio contrast or contrast induced nephropathy, which I will be touching later in the presentation, so you have to consider whether you really need it or whether there is any alternative. Right? If you can have any alternative, not to radio contrast procedures, then of course you may opt for that. Then if the patients develop to the next stage, you can see stage 1, so you have to do the non-invasive diagnostic workup. You have to do the imaging and you have to do other basic investigation to see why the AKI and what to do. And then also you can start considering invasive diagnostic workup at the stage 1. But when it comes to stage 2, there are 3 main things we have to do. First thing, patients would need renal replacement therapy at the stage 2 of kidney disease, acute kidney injury. Sorry. And then stage 2 onwards, patients would need critical support. So considering ICU care is the ideal setup, and also check for drug dosing. So they may be on a lot of medications. So definitely they need reviewing at the stage 2 of acute kidney injury. That is where your kidney function is 2 times, or creatinine is 2 times the baseline. Right. And stage 3, definitely by the stage 3, the patient should be on critical care, and the critical care with renal replacement therapy is established already. So that means you got to be dealing with a specialist, nephrology advisors, when the AKI goes to that level. So what is the renal replacement therapy, the ultimate in the case of kidney failure? So renal replacement therapy, is it equivalent to what you see in the image? The machine, can you see the machine here? This is of course a drawing, patient seated there. So that is a dialysis machine. It is not equivalent to the machine, right? Okay, what do you mean by renal replacement therapy? Renal replacement therapy is therapy that replaces the normal blood filtering function of the kidneys. So you got to keep in mind that is just the replacing the filtering function of your kidney. Okay. So what are the modes we have available? What are the modes of renal replacement therapy we have got? Two main modalities. One is the intermittent modality and then the continuous modality. So the intermittent modality has again two arms. I will come to details. IHD stands for intermittent hemodialysis, which we have access to, and then the second one, what we call the SLED or SLEDD, that is sustained low efficiency dialysis daily or daily dialysis, or EDD, that is extended daily dialysis. When it comes to continuous renal replacement therapy, there are two main modes. One is the PD or the peritoneal dialysis, and the last one is CRRT. I have put it in red because that is the one we need for AKI, and that is what we don't have. Right. This is the same thing again about intermittent hemodialysis and the continuous renal dialysis PD and CRRT. So a little bit about CRRT, that is the continuous renal replacement therapy, and this is the preferred mode of treatment for acute kidney injury now. But this is very particularly for the patients who are hemodynamically unstable and in the critical care or intensive care setting. It is established that this is effective to solute and fluid removal in acute setting. So what are the indications for renal replacement therapy? Mainly there are two categories of indications. The first thing is life-threatening indications and then the non-emergency indications. So the life-threatening emergency or life-threatening indications you got to know, particularly the house officers. So those who are needing renal replacement therapy, when you're calling, you got to know what your indication is for the renal replacement therapy. At least you should know that. Right? So one is the life-threatening indication is hyperkalemia, persistent hyperkalemia despite being giving the initial treatment. Number two is acidemia. Number three is pulmonary edema. Number four, or uremic complications such as pericarditis and sometimes bleeding or convulsions. So those are the four main life-threatening indications, but the other indications are non-emergent ones. Those are like solute management, solute control, fluid removal, fluid control or volume control, and giving renal support, nutrition, drug delivery, and acid-base or electrolytes management, and salt modulation, also solute modulation. Right. So I'm not going to talk to you about how do you dialyze and what are the things we are going to do in the dialysis, because it's very boring. It's going to be already, I can see some of you already having a deep sleep. So I don't want to talk about any of the renal dialysis protocols or anything. So what we expect from AKI is the renal recovery. And how do you define the renal recovery? Complete renal recovery is defined as return to the baseline GFR. As I mentioned earlier, the AKI is stage 1, we defined as more than 1.5 from the baseline. So the serum creatinine, if it goes below 50% from the baseline, like for the baseline, we mentioned that 1.5. So if it is less than 1.5, that we consider as complete renal recovery. You don't have to come to the previous baseline. Partial renal recovery, that is where you don't get the criteria to get the full recovery, that is you don't get the level of below 50% from previous baseline. However, the patient further does not need any dialysis or long-term renal support. But if you patient need regular dialysis going beyond like 4 weeks, then we consider it as a renal loss, and if it goes beyond 3 months, then you label them as end-stage kidney disease. Right, back to the patient. I mentioned the case 1, the lady who came to the surgical ward found to have cellulitis and AKI. We did ultrasound. Interestingly, she was found to have right-sided kidney calculus with hydronephrosis. She had multiple calculi, Stackhorn and PUJ. So, as I mentioned, the protocol, we started fluid hydration, fluid resuscitation, that is the number one in the acute kidney injury management, and then we treated antibiotics, did the wound debridement, so we treated the infection with antibiotics and wound debridement. So the basics done, and then we thought it is AKI or the sepsis causing renal AKI, but now we could find two causes. She's got another cause for her kidney defect. We don't know whether it's just only chronic, acute, maybe element of chronic failure as well. However, she did not have indications for renal replacement therapy, so we didn't start her on any form of dialysis, but she underwent right-sided DGH stent insertion, and AKI is completely resolved and she recovered. This case, I wanted to highlight the fact that all the cases of AKI, so you need to go through the all the causes and then look for all the causes. Like, true that we had one cause for her AKI, but if we had just ignored imaging the renal tract, we could have missed her cause for AKI. So it's a must always you consider all these basic tests, including the renal imaging in case of somebody coming with acute kidney injury. Coming to the case number 2, the gentleman who came to medical ward with septic shock, AKI on CKD. Unfortunately, this gentleman drew MRSA on blood and catheter tip culture. We started the same protocols, IV fluids. He needed inotropes and intravenous antibiotics for his sepsis. He was indicated for renal replacement therapy because he was presenting with advanced stage of acute kidney injury. Unfortunately, we didn't have facility for CRRT, so because that's the only option we can do for hemodynamically unstable patients. So we couldn't support him, and he passed away after 3 days. So this case, I wanted to highlight few things. Just sometimes you might do the basics right, but then if you can't have the ideal setup, you might not get the outcome. We've been trying to get for last couple of years a CRRT. Hopefully there is some hope. There is a potential donor. I think we should be able to get a machine very soon. So for critical care, that is in the horizon. However, the other thing is to make sure that if somebody is anticipating, if somebody is AKI, then you have to act. Anybody who is having high risk, you have to act. If you miss initial stages, it's very difficult to treat. Little bit about contrast-induced acute kidney injury. Contrast-induced acute kidney injury is worsening of kidney function after administration of intravenous contrast media. So you define the stages and the kidney injury the same way as I mentioned earlier. But it is recommended all patients who need assessment with radiocontrast procedures assess their risk for contrast-induced AKI. First thing, use alternative methods if possible, but if there is no alternative, then of course you could use lowest possible contrast dose in the case of high-risk patients, risk of contrast-induced AKI. And also the other option is to use iso-smaller or low-smaller iodinated contrast, or preferred, which is over the high or smaller contrast media, which is more renotoxic. And those who needs still needs you have no other alternate, then of course the recommendations are that you can prior hydrate them. You can't, I mean, there's no place for oral hydration. You have to volume expand with intravenous volume expanders, either isotonic saline or sodium bicarbonate. That is the recommendation for those who are needing contrast procedures. And there's no place for prophylactic hemodialysis or hemofiltration or use of theophylline in the case of patients needing contrast related things. But however, if they develop AKI following the procedure, then of course then of course there is place for uh, hemodialysis or filtration. This is something I just wanted to highlight. This is a 0 by 25 initiative. This is the initiative by the International Society of Nephrology, or the ISN, aiming at reducing the acute kidney injury. So the acute kidney injury, they say, largely preventable or treatable if symptoms and signs identified early and appropriate treatment is given. So this initiative was started in 2013, aiming at eliminating all preventable deaths from acute kidney injury worldwide by the year 2025. So they call for strategies to diagnose and treat AKI and also with potentially reversible diseases. So the mainstay is 5R approach to prevent or get a sustainable AKI program. This first R is risk assessment. So anybody who has risk, then you have active surveillance to look for any potential patients. Now, as you all sometimes you would have seen, this radiology department request forms will have their certain quiz questions. Those who are needing contrast testing, that is kind of active surveillance. You look for any risk factors. Just like that, we should have like more widespread surveillance for people who have high risk. And then the next R is recognition. That is, you recognize the acute kidney injury or the high risk at the point of care testing, with the point of care testing. And then the next thing is you recognize it and then you act, or the response. So you need to act on that, maybe the interventions such as fluids, medications, and then maybe refer them to appropriate medical stations or centers. Then the fourth R is this renal support. When they go into kidney injury or kidney failure, then of course you need to support with renal support. That is either they recommend going for PD, that is for low resource settings, because it has been proven be non-inferior in fluid and solute in the case of acute kidney injury when you compare to PD, RRT or the CRRT to PD. So you can use even PD. And then also getting the nephrologist or critical care support. And the last thing is rehabilitation, when they like post AKI or those who recover from AKI, and then they would need a follow up and then support for prevention of further progression to end stage kidney disease or development of AKI. Any comments or questions? These are my references, and thank you.
I hope that we got the right questions to ask you. As so we have this dialysis today, so that he's in charge of that, and we may be talking to him sometime to get this dialysis done. What is the question that you can ask?
Yeah. Diuretics, of course, AKI guidelines recommend not to use diuretics in acute kidney injury. That's the guideline. I know people practically using that, but there is no guideline, so I can't recommend you beyond the guideline. It is in fact the KDOGI guidelines, the kidney disease guidelines, specifically mention there is no place for diuretics.
So just like even in the medical board, like if somebody is not producing urine, then we tend to start fucoid. Even sometimes they start fucoid infusion. But now it's not much of evidence.
No, there is no evidence or there is no recommendation for that. In fact, I might have even given the same instruction, but there's no kind of clinical evidence or sound evidence, and they recommend not to use it.
That's a very good question. So that because that we still practice that. I don't know whether there's any harm done by using that.
Well, I'm not sure. I haven't read.
So just to satisfy ourselves, because we know that acute kidney injury is like
Maybe that it is not giving any therapeutic benefit. That may be the reason.
We are desperate, like unless that RRT is available, we are desperate that we want to do something. That's why we normally go for it.
Diagnosis is staging according to creatinine and output,
Yeah.
two methods of
Yeah, yeah.
staging. What if the creatinine is rising but still the patient is maintaining?
Now, if you get one criteria fulfilled, you don't have to wait for the other. You act on that. Right? You don't have to wait for the other one to come to that category. Whichever you can categorize, you treat accordingly. Basically, you have to anticipate and act like.
Your clinical judgment also very important.
So because now we have a patient who is on this amphotericin B.
Yeah.
We are monitoring renal
Yeah.
functions daily.
Uh,
As I can remember, baseline creatinine was 0.8.
mm-hmm.
Recent creatinine done yesterday was 2.3.
Yeah.
Then we have reduced the amphotericin dose to half.
Yeah.
But still, according to this, he is in AKI. But the
Yeah.
patient is producing adequate outputs.
Yeah. Yeah, good question. I know this patient. Now, in this case, it is a totally different scenario. Of course, I think Madam might add to that. Amphotericin is also causing renal damage, so this you have to consider as a toxin in that situation. So it's a special situation, but generally speaking, I basically touch upon the baseline or the principles of management. This is a special situation where the patient had long-standing diabetes and is insulin dependent. So we don't know how well his kidneys were like otherwise. We didn't have like an albumin creatinine ratios and other things for him. So he is very high risk. Yes. I agree. He needs aggressive treatment, but what you have done is correct. You have half the dose of amphotericin and then you have hydrated him. I hope he is passing adequate urine. So even though he is that, he is not still stage 3. So we can wait and see. The recommendations are or basically the guidelines. So you use the guidelines to manage, but then that is for your management guideline. Right? Anything to add? Microbiology, madam?
Yeah, I know that patient actually. I'm also very with that patient. This patient is a continuous AKI. Yes, I agree due to amphotericin B. But somehow this is a diagnosed patient with sinusitis with cytomatosis.
Yeah, we have no other option but to use that medication.
We have somehow give the amphotericin. We have to give, and tacrolimus is he need a long-term amphotericin B therapy like for more than 6 weeks. Somehow we have to give amphotericin. That's why we are adjusting antibiotic doses in kidney.
It's a balance between whether you want how you go beyond this, because we need to get the infection control plus see how he responds. But initial, I was told that it will be like 2 weeks and then we'll decide, is it? I don't know. But hope that I answered your question. Yes.
Yes, I think.
Yes.
Yeah. Hi, sir.
Yeah.
Sir, you have given the definition regarding the acute kidney injury.
Yeah, yeah.
In relation to glomerular filtration.
Yeah, 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 yeah.
Sir, I want to know, detecting urine protein and red cells, particularly to the acute kidney injury.
Yeah.
If we can detect these things, can we consider those things as kidney injury?
No, it is not included in the diagnosis of acute kidney injury, but it is useful for your diagnosis of the etiology of the acute kidney injury. That is useful. Like for instance, if it is an intrinsic cause such as acute glomerulonephritis, particularly in the case of vasculitis and all that, you will look for red cells and then the red cell cast and all that. So that is very useful in the case of diagnosing the etiology, but it doesn't come into the diagnostic criteria of AKI. Does that answer your question?
That's it, because can have protein and sediment and carbs and crystals in the urine. So that does not mean that the patient has acute kidney injury. The acute kidney injury is just a deterioration of the renal function within a very short period of time that we need to act quickly. Isn't it? Any other questions from the audience?
Thank you.
Yeah, let me ask another question actually, Ravi, before you wind it up. Just to interrupt earlier, like acute kidney injuries are much more common among surgical patients than the medical patients in surgical units. So actually you mentioned about that, So do you have any advices how to prevent them? Then most of the acute kidney injuries are preventable. So how do you prevent acute kidney injuries in the surgical units?
Right. I'm not sure I have any no data about a surgical wards have higher AKI than medical wards. But maybe that one reason you see it because they are not sometimes very familiar with the management, so they might be detecting it a bit late, and maybe they are like that may be one reason, and also maybe the workload in this hospital, maybe they have the highest number of admissions per unit, if I remember right from the statistics from 2016. And also your surgical patients are, as I mentioned earlier, are high risk uh, for several reasons. One is they more than medical patients, they will be kept fasting or with nil by mouth, as we say, for surgical procedures. So that is one extra reason which I can see than the medical patients. They have a higher risk of volume depletion or low volume to start with. But other than that, and certain other conditions like trauma, injuries, which can increase the acute kidney injury, so they all go to them. So it is the same basic principles. You have to anticipate and then prevent, or anybody who at high risk. I mentioned the stage wise. Any high risk patients, you have to review all that. So you review their medications, volume status, and then take any nephrotoxics away. And also I know that they are using a lot of analgesia in the form of NSAIDs and all. So those have to be like very cautiously done, and also make sure that you do their renal functions or creatinine and input output or urine output measurements routinely, so that we can detect it early.
Thank you very much, Ravi. So that as you
Thank you.
mentioned, right,